Hello, this is Dr. Robert Baughman. My task today is to talk about controversies in sarcoidosis, and I'm going to be sharing with you some slides about this subject. There are many controversies. There's some pharmacologic support that I have for sarcoidosis, both a consultant and on the Speakers Bureau for several years now. Of the many controversies and challenges existing in sarcoidosis in both diagnosis and treatment, I'd like to focus today on three topics. Is a positive biopsy required for the diagnosis of sarcoidosis? Who should be treated for sarcoidosis? And when should a steroid-sparing agent be introduced for treatment? So first of all, is a positive biopsy required for the diagnosis of sarcoidosis? Well, we know that about a quarter of patients in sarcoidosis clinics do not have a biopsy confirmation of the diagnosis of sarcoidosis. The reason can be one, they can be the affected area is not readily amenable to biopsy, such as the brain or the heart, or a biopsy attempt had been made but did not find granulomas. This could have been because there was fibrotic disease or there was patchy involvement. Finally, we know that finding of a granuloma is not specific for sarcoidosis. In general, we say that the way to diagnose sarcoidosis is the presence of non-casein granuloma with no other cause of granuloma, such as TB or Berlin disease, the appropriate clinical setting, but one can never be 100% sure of the diagnosis of sarcoidosis. For example, neurosarcoidosis, a meta-analysis identified over 2,000 published cases of neurosarcoidosis, and it found that over half the patients had neurologic disease at presentation. Overall, only about a third of patients at time of presentation had known sarcoidosis outside of the nervous system. And despite extensive evaluation, 22% of the cases were felt to be isolated neurosarcoidosis without any evidence of extraneural disease. So you can see that biopsy in these cases would be of limited value and that many patients with neurosarcoidosis would have been missed. Cardiac sarcoidosis is similar. We know that cardiac biopsy only makes a diagnosis about a third of the time. If we look at neurosarcoidosis, the criteria, this was a white paper put together by Barney Stern and a group, including myself, we look at the criteria for neurosarcoidosis and break it down to possible, probable, and definite. And possible is the clinical presentation and diagnostic evaluation suggests neurosarcoidosis. This is things such as a positive MRI or a positive CSF, but there is no pathologic confirmation of granuloma disease anywhere, so it only becomes possible. Whereas probable is in the same clinical setting, but pathologic confirmation shows systemic granulomatous disease, such as a positive lung biopsy or EBUS. Whereas definite requires that the neurologic tissue be examined, this either in the brain or say a peripheral nerve, and shows granulomas consistent with sarcoidosis. The American Thoracic Society recently published evidence-based criteria for the diagnosis of sarcoidosis. This was led by Elliot Krauser, Lisa Meyer, and myself, and a group of over 20 experts in sarcoidosis. We came up with this combination of evidence-based and clinical experience for an algorithm to diagnose sarcoidosis. And in this part of the chart, you can see that patients who had highly supportive clinical symptoms, such as Lofgren syndrome or lupus pernio, Herford syndrome, bilateral parotid swelling, or even bilateral hyalinopathy with no symptoms, were highly likely to have sarcoidosis. Those otherwise, where the clinical presentation was consistent with sarcoidosis, a biopsy was recommended, and if it was positive, then the patient could be diagnosed as having sarcoidosis if no other cause was identified. If a biopsy was not performed or the biopsy was negative, then the patient could still have a good diagnosis of sarcoidosis, depending on the strength of the clinical presentation. Since sarcoidosis is a multi-organ disease, it behooves the physician to evaluate every organ, and especially eyes, skin, liver, calcium abnormalities, neurologic disease, as well as thoracic and cardiac disease, because multiple organ involvement is one of the features that helps make the diagnosis of sarcoidosis. We codified this a few years ago, and as I developed this, what was called a sarcoidosis diagnostic score, or SDS. We developed this at the University of Cincinnati initially. We used a scoring system that was based on identifying individual organ involvement. And each organ that was affected by sarcoidosis was given points, 3 points for highly probable organ involvement, points such as hyaluronopathy or lupus pernium, and 2 points for probable organ involvement, such as cardiac arrhythmias. The scoring system was developed for one institution, and we looked at nearly 1,000 patients, half of whom had sarcoidosis, and was validated with a multi-center, multinational study. Well, this is the results of our study at UC, and you can see that if we use an SDS clinical score, that is not with that biopsy, that if a patient had a score of 4 points or greater, they were very likely to have sarcoidosis compared to conditions such as pulmonary fibrosis or COPD or granulomatous diseases or infectious granulomatous diseases or cancer. And so this SDS score clinical was quite solvent. If you added biopsy, which gave you 5 more points, then we got even more specific. To validate this, Florence Jennings led an international study that we participated in, and we asked centers to give us up to 200 patients from each of the 20 centers that participated, and we ended up with 2,000 patients, half of whom had sarcoidosis. You can see that multiple conditions were looked at, including tuberculosis. We had 120 cases, and non-infectious granulomatous diseases such as ankylosing spondylosis and common variable immune deficiency. Where these are relatively rare, they are still have to be considered patients with sarcoidosis. Dr. Talwar and Dr. Bhattacharya from India participated in this study, and we did look, as I said, a large number of patients with tuberculosis. What we found was that there was a distinct difference between those patients with sarcoidosis and other conditions. You can see on the left the sarcoidosis diagnostic clinical score. And if you look at those patients who had a score of less than 3, very few patients with sarcoidosis had a score of less than 3. And the majority of patients with scores of greater than 5 or more were sarcoidosis patients far and away. If we added the biopsy, the criteria for diagnosis now gets up to a greater than 5. And you can see that for sarcoidosis, no patient had a score of less than 5. And this is because the study required that the patients have a diagnosis of sarcoidosis by biopsy confirmation. Yet there were some patients with positive biopsies, but almost no patient had a score of greater than 11. So you can see that we were able to distinguish between sarcoidosis and other conditions for the most part. So we were left with this algorithm that we proposed, that if a patient had a SDS clinical score of greater than 9, that you could feel highly comfortable with the diagnosis of sarcoidosis. If their score was between 3 and 9, and a biopsy was performed that was positive, then you could also feel very comfortable with the diagnosis of sarcoidosis. If their biopsy was not performed or was negative and their score was still greater than 4, you had probable sarcoidosis. Now there's one hedge here. Patients who had beryllium exposure, ankylosing or CVID, common variable immune deficiency, could have high scores. But these patients could be ruled out by a history and blood work, appropriate blood work, such as quantitative immunoglobulins. The next controversy I'll move on to is who should be treated for sarcoidosis. In general, there are only really 2 reasons to treat patients with sarcoidosis: to avoid danger or to improve quality of life. And danger means death or loss of organ involvement. So what factors are important to diagnose patients with sarcoidosis? This is a survey of 1,842 patients with sarcoidosis. The most important to the patients was improvement of quality of life and functionality. Less important were things such as pulmonary function tests or blood tests. Survival was kind of in the middle, and this is appropriate since survival is not usually a factor in patients with sarcoidosis. So what happens to the patient who's asymptomatic? We have an older study done by the British Thoracic Society where they identified nearly 150 patients who were asymptomatic but had parenchymal lung disease. And this group of patients were followed for about 6 months. During that 6 months, 22% of the patients became symptomatic and required therapy by their treating physician, healthcare provider. Approximately 40% actually showed radiologic improvement and never needed any therapy. Of the patients who were in the center, that is, that they had persistent parenchymal disease with no worsening, they were randomized to receive either prednisolone for 18 months or only to receive prednisolone if they became symptomatic. And it's this small group of 31 patients that were asymptomatic after 3 months that 20% of them developed symptomatic disease, 5 for pulmonary disease and 1 for extrapulmonary disease, in this case, lupus pernium. So in general, an asymptomatic patient who doesn't become symptomatic in the first 6 months has a pretty good chance, only about a 10% chance or so, that they're going to go on to require systemic therapy for the disease. So if we look at a Delphi of sarcoid expert, asking them about who should be treated for sarcoidosis, they separated those patients with symptoms or no symptoms. Frank Wahaki and myself ran this Delphi, and we did a series of questions asking people and tried to identify which factors would be important. So if you took, for example, the forced vital capacity, and someone who is symptomatic, if their forced vital capacity was less than 70% or even 70 to 80%, there was a consensus that those patients who were symptomatic who had the reduced forced vital capacity should be treated. On the other hand, if they were asymptomatic, even if they had reduced forced vital capacity, there was no consensus that they should be treated. There was also no consensus that they should not be treated. And so some people would say, well, we may want to treat them. The same thing could be said for DLCO, where again, the cutoff was between 70%, 80% or less. There was a consensus that if they were symptomatic, they should be treated for their pulmonary disease. Chest x-ray, same situation. Again, not looking at symptoms versus asymptomatic, only symptomatic patients with their consensus for treatment, either on the abnormal chest x-ray showing parenchymal disease, scanning stage 2 or 3, or fibrosis scanning stage 4, or if there was fibrosis on HRCT. There was near consensus against treating patients who had a stage 0 or 1 and asymptomatic, but there were still some people who would consider therapy for an asymptomatic person with an abnormal chest x-ray, and therefore no consensus was made there. There was very strong consensus that if there was a change in the chest pulmonary function test, or the vital capacity, DLCO, or FEV1, FVC, any of those three, that the patient should be started on therapy. The same breakdown between symptomatic and asymptomatic was identified in patients with extrapulmonary disease. And here it's interesting that patients with asymptomatic disease who had renal involvement, eye involvement, neurologic disease, or cardiac involvement, before there was a consensus that they should be treated. Whereas that those patients, only those patients with hepatic and cutaneous only should be treated if they had symptoms from that manifestation of the disease. So how many patients with sarcoidosis don't need treatment? Well, this is a clinical outcome score that a group of us at WASOG developed, looking at centers across the world. And we broke down the clinical outcome of patients that have been observed for 5 years. And there were various options that could happen. They could resolve with never being treated, or they could have been treated but had been on therapy for a year. And you can see the other breakdowns. But there are 3 general categories: never treated, resolved, minimal disease but never treated, and persistent disease but never treated. And if you look at what happened at these 10 centers across the world, 500 patients from each of the centers, that varied depending on whether the center was in Italy or Europe or Cincinnati or Kyoto, that 30 to 50% of patients never were treated. So in general, about a third of patients with sarcoidosis never require therapy. And it's currently important to identify those patients who do not need to be treated. So when we developed the European Respiratory Society evidence-based recommendations, with Dominic Valère and I running this committee, we separated patients into 3 general categories. We looked at the patients with low risk, as the Delphi had already identified, and those patients did not need specific therapy. Basically, they were asymptomatic, and the recommendation was to observe them with the understanding that about 10 to 20% of the patients over time would develop symptoms or worsening of their pulmonary function test, in which case therapy should be initiated. And that the remaining patients, that is up to 2/3 of patients, should be considered for therapy. And they should be considered for therapy either on the basis of high risk for mortality or organ loss versus impaired risk, but impaired quality of life. And the recommendations in this, by the way, were made, the evidence-based recommendations of strong or conditional recommendations for like methotrexate and infliximab were based on trials that were only done in patients that were high risk for organ involvement. But the committee felt that these same recommendations and drug order could be used for patients with intermediate risk. So we've decided to treat patients. The next controversy is, when should a steroid-sparing agent be introduced for treatment? So in the ERS guidelines, we quickly focused on the fact that patients who are started on glucocorticoids should be started on glucocorticoids, but should be successfully tapered on their steroids. And if they're not successfully tapered down on their steroids, that they should be started on an alternative agent. And the conditional recommendation was methotrexate based on the evidence that I'll show you. So when should a non-biologic, that is drugs like methotrexate or azathioprine, mycophenolate, be considered? Getting back to the Delphi that had done the year before, patients with severe disease, that would be a consideration. But the most common were patients that steroids were not effective, or they were prolonged high-dose steroids or toxicity. And in those situations, there was consensus for starting them on steroid-sparing agent. There was no consensus on putting it on all patients with sarcoidosis. It is interesting, there is currently being studied done by Jan Gruters and Marcel Veldkamp looking at steroid versus methotrexate upfront for acute disease. And the results of that trial may change our approach, but currently we think it is the second step. Why methotrexate? That was actually the one that there was a consensus as the most commonly used agent, steroid sparing. This is based in part on a double-blind placebo-controlled trial comparing methotrexate versus placebo in patients initially started on prednisone for their acute disease. And you can see after 6 months, those on methotrexate continue to have their dose of prednisone reduced, whereas those on placebo will start having relapses of the disease and have to go back up on their dose of prednisone. In another study done in Holland and Belgium, the methotrexate was compared to azathioprine. This is a retrospective study looking at 2 sites. One site chiefly used methotrexate, the other uses azathioprine. And if you look at chronic sarcoidosis patients placed on these drugs, you can see that both drugs reduced the dose of prednisone by a mean of 10 milligrams over the first year. Both of them led to improvement of vital capacity, and there was no real difference in the clinical outcome, but there was more discontinuation of azathioprine, almost twice as much. And this is due to side effects, basically infections. So methotrexate is a fairly safe drug. We introduced this drug more than 30 years ago at Cincinnati, and this is an experience, our own experience, a few years ago that we published looking at 607 patients seen multiple times during a 6-year period with blood work available. You can see that rarely did we see liver function abnormalities as evidenced by an elevation of ALT of more than 3 times upper limit of normal, and rarely did we encounter leukopenia related to therapy. It was less than 2 patients out of the 607 that we treated. So I think that you can say that this drug, if monitored appropriately, can be a very safe drug in patients as a steroid-sparing agent. But what about using it as an upfront therapy? And in the evidence-based guidelines, when we look at other organ involvement, as I said, for severe disease, there was the Delphi raising that question. So in cardiac disease, the evidence-based guidelines suggest that glucocorticoids be started on patients with clinically relevant cardiac sarcoidosis, and to consider plus or minus adding methotrexate as initial therapy. And many clinicians would do this, including ourselves, and only if you aren't able to successfully reduce steroids, to consider doing another non-biologic, or to consider adding one of the biologics for cardiac sarcoidosis. A similar recommendation was considered for neurosarcoidosis, although it was not as strongly recommended for neurosarcoidosis, basically because there was little evidence of adding methotrexate up front with glucocorticoids. But frankly, we do that in our practice. So I think that one can consider in patients with chronic severe disease, such as neuro and cardiac sarcoidosis, to add a site of non-biologic at initiation of corticosteroids. What about biologics, specifically infliximab, but other biologics can be considered. There was consensus for giving this for progressive disease, especially when steroids and non-biologics failing or they become toxic. There was no consensus of giving a biologic agent immediately after giving corticosteroids. Most of the committee felt that a non-biologic should be considered initially. And if you're giving a drug such as infliximab, even if you're going to give infliximab, you should add on a drug such as methotrexate to avoid autoantibodies. So what is the outcome of steroid-sparing agents in sarcoidosis? We still don't have a lot of information. This is one of our challenges. We don't know, for example, how often it's employed in general clinical practice, how frequently are patients weaned off steroids once they're placed on these biologics, and how often is a combination necessary. To look at this, we looked at our patient population, specifically ocular disease, since we felt that this is a group that would often have chronic disease and require long-term treatment. So our general approach at the University of Cincinnati is to take symptomatic ocular disease, especially those with moderate to severe disease, such as posterior uveitis, and they treat initially with periocular steroid injections, topical steroids plus or minus prednisone, but quickly to add on drugs such as methotrexate and to follow this algorithm considering other agents. Well, if we look at this, this was published back in 2012. If we look at this, at the time, we looked at 1,612 patients seen in our clinic, and we had approximately 30% of them having definite probable eye involvement. And you can see the majority of patients following our algorithm were placed on methotrexate as a steroid-sparing agent. Since eye toxicity, such as cataracts and glaucoma, are a big problem with systemic steroids, where there was a big initiative to get patients off of prednisone for their ocular disease. So those patients treated with methotrexate, at the end of the day, about almost 80% of them were still on methotrexate. There were only a few patients who were able to get weaned successfully off methotrexate. So this is an example that once you're on methotrexate for this type of chronic disease, you're going to stay on this type of therapy. So what happened to these patients? Of the 281 patients still on methotrexate, almost a half of them were still on prednisone. This despite the fact that we had added it on specifically to get them off the prednisone. So we had various combinations. The most common was to give prednisone and methotrexate, but you could also see the addition of other agents such as flavonoid and other non-biologic, or we could even consider giving anti-TNFs, which we did with or without prednisone, and in a small but significant portion of patients. This is back in 2012. Over the last 10 years, we've been more aggressive about using anti-TNFs, especially since they've now been approved for chronic uveitis by the FDA. So getting back to the European Respiratory Society for pulmonary disease, then we have the recommendation that patients who have not been successfully tapered on corticosteroids with methotrexate, that a conditional recommendation is infliximab or another one of the biologics. There is more evidence to support infliximab than there is other biologics, which is why the conditional recommendation is to use infliximab first. And this is 2 double-blind placebo-controlled trials done comparing infliximab to placebo in patients on corticosteroids, and they showed an improvement in vital capacity as well as steroid reduction. And over the years, we've developed an algorithm of a set of recommendations for who should be considered for infliximab, specifically chronic advanced pulmonary disease, especially those with ongoing inflammation as evidenced by an elevated CRP or soluble IL-2 receptor, or more commonly the PET scan, since that's a much more widely used indication. Other organ involvement such as lupus pernio, neurologic disease, refractory eye disease also lead to consideration for infliximab therapy. And so the European Respiratory Society, as I said, expands the recommendations for third-line therapy to include other anti-TNF agents such as adalimumab, and to consider other novel agents such as rituximab, JAK2 inhibitors, or repository corticosteroid injection. And these really should be considered on a case-by-case basis. I'm going to finish up with just a discussion of the fact that for third-line therapy, the ERS guidelines ended up with 5 drugs that were in the recommendations, and really only one had a conditional recommendation of any strength, and that was infliximab. On the other hand, for rheumatoid arthritis, there are multiple agents that are available, well investigated, part of this because they were required to get FDA approval. And we know that these biologics have a limited lifespan because patients often have the drugs discontinued. This is our experience at the University of Cincinnati of over 400 treatment regimens, including infliximab, adalimumab, repository corticosteroid injection, and rituximab. And you can see approximately half the patients have to have the drug discontinued over time. Using a Kaplan-Meier curve, we can talk about the survival of an individual drug. In this case, looking at infliximab, the solid versus the other treatments. And you can see that by about 6.5 years, 50% of patients on infliximab had to have the drug withdrawn. And that some of the other agents, such as rituximab, had a longer half-life, that is, they can continue. And obviously, one can switch from one drug to the other, which is a common practice in rheumatoid arthritis and becoming more increasingly pursued in sarcoidosis. Why do we stop the drug? In our study, the most common reasons were infection and adverse events, and they were significantly more common with infliximab than they were with the other agents. Insurance is another reason, frankly, that we have to see an overall toxicity other than severe adverse events such as allergic reactions to the drug were seen with all 4 agents. So in conclusion, the diagnosis of sarcoidosis is a combination of clinical features and biopsy. Some patients can be diagnosed without biopsy, and I'm giving you clinical criteria for that, but you always must consider alternative conditions such as tuberculosis and non-infectious causes of granulomatous disease, such as common variable immune deficiency. For the most part, we still believe that initiation of treatment is based on the presence of symptoms, but there are exceptions. And a stepwise approach to therapy seems appropriate to reduce toxicities. And we now have evidence-based guidelines to help in that regard. Thank you very much for your attention. I'm going to stop at this point.